to the question and answer session of the day. So we have a couple of questions and I will address them to individual speaker. Lalit Mohan Sharma has asked a question to Dr. Seema. Dr. Seema, very good overview. Can you comment on low dose ibrutinib after 2 or 3 months of full dose ibrutinib? Dr. Seema.
So, as far as the dose reduction is concerned, there is no data which shows that dose reduction should be done after once you start with the full dose, and then if you have a good response, reducing dose. We do not have actually data which encourage us to do that to avoid AIDS. But in real world, so many people are doing like that because of the comorbidities and associated concurrent drug and to reduce adverse events. But there is no actually data which support.
Thank you, Seema. I may just quote there the Netherlands study of Dutch people, which is just a one-center study, where what they did was all those patients who could not take full dose because of either atrial fibrillation or some bleeding tendency or any other reason, they went on analyzing those patients. And at the end of about 2 years, at least they have presented this data that the efficacy was similar to full dose. And in fact, in the Western world, that made J&J remove the tablet of 140 and 320 so that every patient is kept on 420. The next question is from Dr. Santosh. How to manage when atrial fibrillation occurs? Can we restart ibrutinib afterwards? Which anticoagulation to use and how long? Seema?
So, as far as atrial fibrillation is concerned, it depends on what is the grade of atrial fibrillation, like whether it is a symptomatic or just asymptomatic, no drop of BP and no syncope or dyspnea or exertion. So, it all depends. We have to take in consultation of the cardiologist whether they want to intervene and control the rate of heart with the antiarrhythmic. So if antiarrhythmics are advised, then definitely you need to adjust the dose of ibrutinib, because many of them like cardaron or verapamine, they are moderate inhibitors and they might increase the activity of the ibrutinib. So it has to be reduced. And then secondly, we have to evaluate whether these patients are at the risk of stroke or not. So if risk of stroke is like there's a scoring system and it shows its risk is 1 or more than 2 and requiring anticoagulation, then in that situation, apexaban has been recommended, can be added with the ibrutinib in a dose of 2.5 or 5 milligram BD. And second option is dabigatran. 150 BD is the recommended dose, but you can reduce it to 110 BD. As far as antiplatelet drugs are concerned, single antiplatelet drug administration with ibrutinib is okay, but when it comes to double or triple antiplatelet drug addition, you need to, in triple definitely you need to hold the ibrutinib. Once this atrial fibrillation episode is under control, you can restart with the ibrutinib, and as has been mentioned in the data, its occurrence usually reduces over a period of time. And the risk of having atrial fibrillation is most when patients are more than 65 years of age and if they have an earlier episode of AIDS.
Thank you, Seema. The next question is from Dr. Lalit Mohan Sharma. It's about what is the longest duration of ibrutinib in real life clinical practice, and he says that Dr. Agarwal has to answer this.
Yes, because you have a greater experience of using these drugs.
So
Yes, sir.
if
We would like
Lalit,
to
you
know.
are asking about my personal, it is 3 years, and internationally it is almost 7 years if you include the patients who were a part of the trial. Next question is from okay. There is a request to start my video, so I have started my video. Okay. So next question is from Jakiyamani. In elderly patient with comorbidity with hypertension, IHD, CKD, can we use ibrutinib in the usual dose? And if not, then what should be the dose and what should be the duration? Seema? Seema, you are
So,
bombarded with questions.
so as such, hypertension or CKD is not a contraindication for ibrutinib, and no dose adjustment has been recommended. In IHD, you have to see whether you are giving one antiplatelet drug or doublet or triplet, and accordingly, then we have to manage depending upon the bleeding complications.
Okay. Next question is again to Dr. Seema from Shilpi Saxena. Ma'am, can an incidentally diagnosed asymptomatic CLL be started on ibrutinib, and what is the minimum absolute indication to start ibrutinib?
So minimum absolute indication is just like any other for any other therapies. Like we don't start treatment at stage 0, and there are criteria to indicate whether patient can be started on uh, therapy or not. There has to be a progression, like in for any other therapy. Starting therapy, we always see whether lymphocyte doubling count is rapid and causing more than double within 6 months or not. There is a progressive increase in organs or not, which is causing compressive symptoms, lymphadenopathy, platelet less than 10,000, hemoglobin less than 10,000. So asymptomatic stage 0, no role of ibrutinib.
Right. So I may just once again add that there is a work going on in Germany, and what they are trying to do is to look at patients who do not fulfill the criteria of treatment, give them ibrutinib, and see whether it changes the natural history of the disease. Now, the world is not convinced that whatever is the outcome of this data, whether one would ever give a drug like ibrutinib, which, if you look at in the long term, is reasonably toxic.
The similar data was there on FCR also, whether we can decrease the, means whether we can avoid the progression, but it didn't show any evidence to start with at stage 3.
Right. So, according to what I see, there are no